Dr. Neha Dholakia, which will be represented by Dr. Pankaj.
Taking into consideration the original talk is by Dr. Neha Dholakia, and due to some reason she couldn't attend this talk, attend this session, so she asked me to present it. Sir, your idea was very good. Just I was thinking, if the needle is slightly heated, all the edges will become more rigid, and the extension chances will so
उसको
heated
गरम कर दो.
heated needle अगर रहे तो
स्कार हो जाएगा
right.
और ही
If you
अच्छा.
have RF cautery, that needle can go inside and work. Just I was discussing, and the same thing came to both of us mind at the same moment. Yes, definitely he had that, but that way it will be great.
He is also an innovator, no? So innovator versus innovator, yeah.
Okay, thank you. I will be just talking about the IOL cutting. Broken IOL complication is not uncommon for any surgeon. So these type of implants and mishaps can happen any time in our OT, and we should be ready to deal these type of complications and to prevent the dreaded complications of corneal edema and wound enlargement causing a large amount of astigmatism. We need to have a better techniques. There are already many techniques described, like cutting the IOL into two pieces, cutting the IOL in the half, and but all these procedures cause a lot of stress on the cornea and can cause corneal edema and Descemet's membrane detachment. So we came up with instrument which can be attached to any phaco machine, and the cutting of IOL will be done by ultrasonic power, and that way it becomes much easier. So making a multiple pieces of the IOL in the anterior chamber become very easy, and all of us are having a good ultrasonic machine, so anybody can have this tip attached to a phaco handpiece and use this as a IOL cutter. This is developed by Dr. Neha Dholakia, and once these pieces are made, each piece can be separately taken out. See, the procedure is very simple. Once you tune your machine, you just have to attach it to the phaco probe. This is the additional handpiece which is provided, another forceps which is provided to hold the IOL, and this is the experiment. We are cutting ex vivo, and it cuts like smooth like a butter. So someone really need to see how ultrasonic, there are ultrasonic knives also available which can be used even in kitchen, and once if you see it, you will understand how ultrasonic power can be utilized to cut the IOL. The only difference which is you need a longitudinal power, as the needle is not hollow, so you don't need. So this is the demonstration, like this type of acrylic material you cannot cut with a normal knife, but once you use the ultrasonic power, see how smoothly it is coming with smooth edges. It can be used to any machine. You need not to have a separate machine for that, so no big investment for that. Sometimes IOL exchange become is necessity because of the caused glare and halos due to multifocal IOL, sometimes not suited to the patient. In such scenarios, the expectations are very high, and IOL exchange becomes necessary. In such cases, to take the risk of PC tear and damaging the damaging the cornea is not possible. So here you are much safer. This is a opacified IOL, hydrophilic IOL, and it was a very thick IOL done by Dr. Kamal Kapoor. And see how easily it has broken a very thick IOL in the anterior chamber itself without causing much damage to the endothelium and not risking the bag at all. So these type of broken IOLs or decentered IOLs can be exchanged comfortably, and any type of material can be exchanged. It does not, you need not to increase the size of your incision, that's why you need not to use this thing. It will not be causing any astigmatism, though definitely an emergency vitrectomy cutter should be available. The cutter is available in the market at iolcutter.in. Now once this is done, I had extended the use of this particular technique to cut the nucleus into multiple pieces, and here I am just showing a case of very hard cataract, grade 5 cataract, which is very difficult to cut with even best possible machine. So I have taken the left hand instrument is a nucleus sustainer which will hold the nucleus in place, and see how easily this ultrasonic pre-chopper can cut the IOL into multiple pieces. This is working very nicely. I have done more than 70 cases with this, and I have posted many of them on YouTube channel, and those works very well. You can make 8 pieces. This type of cataract cannot be broken with even femtosecond. So this is a very cheap option, very nice option, slight learning curve, but it can cut the nucleus into multiple pieces very comfortably, and it will work wonder. I usually use 2 phaco machines at the same moment. I have AMOS ovarian compact machine which is having ultrasonic pre-chopper, and now I have shifted to a normal phaco machine which is Alcon phaco machine, and this is followed by a routine phaco emulsification procedure. So somebody is having one single machine, he has to change the tip and then proceed. This is a patented technology. Thank you so much.
Kindly introduce yourself.
Myself, Dr. Pankaj Lande. I practice at Amravati, Maharashtra. I have been in process of thinking about using this particular type of thing, but I approached few companies. They couldn't make it. Then once I saw Dr. Neha's needle, and then I had idea to use this, and to cut the nucleus, it works wonders, sir.
So you're going to replace FICO.
Nothing can be replaced, sir.
Yeah.
But for pre-chopping, definitely, because
Yeah.
I have more than 10 surgeons who previously used to use a mechanical chop, and they got shifted to this one. Slight learning curve of 10 to 15 cases. Once they are done, they feel like I'm so comfortable using a ultrasonic pre-chopper. I feel I got so much zonules if I go for a mechanical chop, and I'm always scared of using it. While using this, it cuts like butter, and very hard cataract is a pleasure rather than a scare to me while operating.
Now, how
So-
deep you go?
Sorry, sir?
How deep you go?
I go more than 2/3 of the area.
And
Yes,
rest,
you need
rest
to
you
have.
crack.
Yes, sir.
Okay.
It cuts like just like butter. It goes inside. The design itself is nice. We
That
have
is
slight.
fine, but how would you know that you're not cutting the posterior capsule, you're cutting only the nucleus?
Somebody who is used to with the horizontal horizontal phaco technique, no, he's used to with going to the equator with the left hand. People are finding it difficult to use the left hand and not the right hand. The left hand instrument should go to the equator and stabilize the nucleus, so that once the nucleus is stabilized, you just have to keep that hand there, and then right hand has to proceed. Right hand, yes, slightly deep has to go.
How
I-
much deep? And
Yes,
how will
that's
you
what
differentiate
we are
that two
planning. We are
surfaces?
planning to make a mark over the tip, so that
Achha.
how deep it is going inside. We are planning to like introduce that. Some new models we are trying, sir.
The concept is good.
Right, sir.
But it still remains the blind procedure, and you have to, I think, have your own mental image, how deep you should go, and safety question will always be there. But looking into handling these hard cataracts are anyway difficult. So idea is very good.
Thank
Very
you,
good,
sir.
very good idea. Any remarks?
What is the
Energy.
sir? Energy usually required is 30 to 40%. You need not to put the means vacuum. You can put to 0 because there is no bore to the energy for IOL cutting. Energy 30% is more than enough. Yes, what Dr. Kamal Kapoor's case, that type of very hard opacified lenses may need a energy up to 50. Sir, the good part of the story, if even they use 100% energy, the tip is so small, the energy dissipation in the surrounding area is so low that it is not going to cause much of a damage. So if you want, you can use as much as energy you want, and it will not dissipate in the surrounding area. It will not cause any tissue damage at the end of the day.
I think it's a very good idea.
Thank
Overall,
you.
yeah, it's very killing. It's a killing idea actually.